Hello guys, today we are going to continue understanding the neoplasia. It's lecture 2 in the locomotor system in the diseases or pathology, which is the science of studying diseases. The lecture will be divided into two parts. One part will be today, which is the recorded part. The other part will be next Saturday, if God will. And it will be an interactive part on the Zoom, and it will be recorded and uploaded to your YouTube channel and LMS on Saturday after finishing the live session. So let's now revise quickly what did we learn in the previous lecture. First, we talked about tumors, and we said that tumors are autonomously proliferating cells. We cannot control their proliferation. They don't obey the normal laws of the body, okay? And we said that we classify tumors according to either tissue of origin or behavior. And usually we combine both in the tumor's nomenclature, on their nomination system, right? So if we classify tumors according to the tissue of origin, we have two major types of tissues: the epithelial tissues, in which includes the cells that line or cover body systems, like the skin, for example, or the lining of the respiratory tract, and so on. And we have the mesenchymal tissue, like the muscle, bone, fat, and so on. So we classify tumors according to the tissue of origin. And whether epithelial or mesenchymal, they have one of three behaviors, right? One is called benign, in which the tumors are well defined, usually, not always, capsulated. They grow by compression of the surrounding tissue, not invasion. They are well differentiated under the microscope. They have low mitosis, less hemorrhage and necrosis, right? And they don't spread, they don't do distantly, or they don't do metastasis, right? And we have an intermediate type of malignant tumors. It's called locally malignant or locally aggressive tumors, in which the tumor cells have malignant criteria under the microscope and grow by invasion. They spread directly. They do direct invasion into the nearby tissues, but they don't send distant metastasis. And finally, we have the malignant tumors that are rapidly growing, non-capsulated, invasive to the surrounding tissue, and sending distant metastasis to organs. Malignant tumors don't have capsule under the microscope. They may be well differentiated or may have anaplasia, in which the grade of differentiation may be moderate, poor, or undifferentiated. We also described malignant tumors as having grossly as having one of three shapes. One is the cauliflower or fungating mass, one is the infiltrating mass, and one is the malignant ulcer. We defined some medical terms, and we said that neoplasm is the same term like the tumor, which is an uncontrolled proliferation, uncontrolled cell mass proliferation. Cancer is the malignant tumor or the malignant neoplasm. Invasion is the direct nearby spread of tumor cells into surrounding tissue, and it is a feature of malignant tumors. Metastasis is the distant spread of cells into distant organs, and it is a feature of malignant tumors. Differentiation is the extent to which the tumor cells are similar to the original cells under the microscope. And we have 4 grades: well differentiated, moderately differentiated, poorly differentiated, and undifferentiated. Okay, and most benign tumors, or nearly all benign tumors, are well differentiated, while the malignant tumors may be well, moderate, poor, or undifferentiated. When the undifferentiation is ranging from moderately differentiated to undifferentiated, this is called anaplasia. Okay, and the last definition is the angiogenesis, Angio means blood vessel, genesis means creation, and the process of angiogenesis is the process in which the tumor cells create new blood vessels like that to supply them. Regarding the differentiation, when the cells of the mass are similar to the original tissue, they are called well differentiated. While if the cells have criteria that makes them differ from the original tissue, they are classified from moderate to undifferentiated. Okay? Under the microscope in malignant tumors, we also search for microscopic criteria of malignancy, which are the features that make us think that these cells are malignant. One of the features, like we said in the last lecture, was the increased nuclear size, which is called increased nuclear to cytoplasmic ratio. The other is the severe darkness, the blue staining of the nucleus, which is called hyperchromatism, in which hyper means increased and chromatism means staining. And also, some cells have nuclei that are vesicular, open, have open chromatin with nucleoli, okay, which is this one, and this is called vesicular nuclei. Some cells also may have multinucleation, right? And some cells may have many normal mitosis. Remember the stages of mitosis like metaphase, anaphase, telophase, right? We will have numerous mitosis because the cells are proliferating rapidly. Moreover, we may have abnormal shapes of mitosis, like star-shaped one, like sun rays, like ring-shaped, like Mercedes shaped, and so on. The more these features are in the tumor, the less differentiation is the malignant tumor. Also, we already said that in order to diagnose a malignant tumor, we need to have changes in cell morphology, which we already explained, and we need to have changes in cellular architecture, which means that organization of cells is abnormal. Cells does not respect the normal order of them in a normal order of the tissue and the normal structure. But these two features are not enough to diagnose a malignant tumor. We also need to have invasion of the surrounding tissue, okay? To have to say or to name a tumor that is malignant, we need to see invasion of the nearby tissue, okay? We don't need to see distant spread, or no, we don't need to see metastasis, but we have to see invasion. Why? Because if we have a tissue that have abnormal cell morphology and architecture without invasion, it will have a different term from malignant tumors, and we will explain that later in this lecture. So let's start our lecture, in which our focus is to explain more criteria of malignant tumors. And just for revision, we said that malignant tumors can have this cauliflower fungating shape, right? Or the malignant ulcer in which the ulcer is raised. I think this picture is more clear than the previous one in the previous lecture, right? The ulcer here, this ulcer is raised above the surface, right? This is the surface, it's raised, and the edges. Do you see the edges here? This one and this one. They look outside, right? They look externally, or we can describe them as everted. Okay, so this is a malignant ulcer with raised everted edges, and we have a third shape, which is an infiltrating mass with irregular borders like that one. Okay, these are three common shapes for malignant tumors, but we have also other shapes that we didn't mention in the previous lecture, and we are going to mention in lecture number 2, like this one and this one, and leave the shapes for further explanation later. So our objective for this lecture is to, first of all, continue the explanation of some of the complications and causes of death of neoplasia. We, in the previous lecture, mentioned some complications and causes of death for both benign and malignant tumors. We need to add one complication, Also, to explain the causes, the etiology, and basic concepts of pathogenesis of tumors, and we will focus more on the cancers, okay? Then we will explain more the metastasis or the distant spread of tumors, okay? And we will focus on bone as one of the common sites of this distant spread, because we are in the locomotor system and bone is one of the components of the locomotor system. So let's discuss our first objective. We have an additional complication or a potential cause of death in neoplasms. It's called paraneoplastic syndrome. Paraneoplastic syndrome. Para means beside. Neoplastic means neoplasm or a tumor. Syndrome means different symptoms and signs that are unrelated to each other. So paraneoplastic syndrome is a condition in which we have different symptoms and signs that are not related to it. We cannot form a connection between them, a clear connection between them. And they arise because of a beside function of the neoplasms. Okay? In other words, the neoplasm may secrete hormones or other proteins that give a picture of a disease that is not related to the original tissue that the tumor arises from. Okay? Sometimes the paraneoplastic syndrome is due to an immunological reaction to the tumor from the body. And the symptoms of paraneoplastic syndromes differ from one tumor to another. Sometimes the symptoms are endocrinal, sometimes it is neuromuscular, like weakness in the muscle. Sometimes it is musculoskeletal, like weakness in the bone, hematologic, gastrointestinal, renal, and so on. The importance of paraneoplastic syndromes is in one of these things. One, it may cause death because it may cause serious complications. The other one is sometimes the patient does not present to the clinic with a mass, okay? And the patient is ignorant about his disease. He just presents with the paraneoplastic symptoms, not the tumor itself. So the physician must be aware of something like that and search for a tumor, a hidden tumor inside the patient's body. Let's see some of these as examples to understand the concept of paraneoplastic syndromes. Sometimes some of the tumors causes hypercalcemia. Although these tumors actually originate from tissues that have no relation to calcium regulation in the blood. For example, the lung cancer. Some types of lung cancer causes hypercalcemia in the blood. And the patient may just present with the hypercalcemia, just he is doing a regular checkup for blood analysis and he finds a hypercalcemia. Or maybe he is presenting with multiple stones in his kidney, for example, and then the blood analysis discovers hypercalcemia without a known cause. We know that one of the hormones, for example, that is responsible for calcium regulation is the parathyroid hormone, in other words, the paras hormone, okay, which arises from the parathyroid gland in the neck. If we find a hypercalcemia, we usually investigate a disease in the parathyroid gland. But in this patient, no abnormality is present. The parathyroid hormone is normal. So where is the disease? What caused this hypercalcemia? Maybe a hidden tumor that have the capability to secrete a parathyroid hormone-like protein. It's a protein, actually, not a hormone. Paras hormone-like protein. This secretion, this protein, this paraneoplastic function will be the cause for this hypercalcemia and may indicate that we need to search for a cancer, for example, lung cancer. Another example is that some tumors may cause hypercoagulability of blood. They make the blood form more thrombi, okay? And this may be fatal because if you remember from the basic medical sciences modules, the thrombosis, venous thrombosis, can lead to a detachment from the thrombus after some time, and this thrombus circulates in the blood in a form called embolus, which may obstruct a small branch of an artery to another organ. And the most common site or the most common organ for obstruction by this detached thrombus is the lung, in a disease called pulmonary embolism. So this was our first objective, which is explaining the paraneoplastic syndrome as one additional complication or cause of death in tumors. And by the way, the paraneoplastic syndrome is mainly in cancers, in malignant tumors, not in benign tumors. It is rarely present in benign tumors, but however, the usual rule is that paraneoplastic syndrome manifests in malignant tumors, and not all malignant tumors can have paraneoplastic syndrome. The second objective is to understand the etiology and pathogenesis of cancer, which is called carcinogenesis. Carcino means cancer, which is a malignant tumor. Genesis means creation. So carcinogenesis is the process of creation of a cancer. It is the transformation of normal cells to neoplastic cells. Okay? And actually, no single factor will cause cancer. Actually, cancer is a combination or an interplay between exogenous and endogenous factors. Some say environmental and genetic factors. In other words, we meet or we expose ourselves to an exogenous or environmental factor that will, in the predisposed people, stimulate a genetic alteration, which both will cause a cancer. These, the environmental or exogenous factors may be chemical, physical, infection with viruses, and the endogenous or genetic may be mutations in genes, either overexpression or inhibition, like we will explain soon. So regarding the etiology and predisposing factors, we may have carcinogenic agents. We may have precancerous lesions inside the body. Okay, so regarding the predisposing factors, one of the factors is the geographical distribution. We found that certain types of cancer are predominant in certain countries. Like in US, in males, the predominant cancer types are the lung, colon, and prostate cancer, while in females, the lung, colon, and breast cancer. So the lung and colon cancers are predominant, okay, in US. While in Japan, we found that stomach cancer is very predominant, okay? So it is a difference in the geographical distribution, right? Also, in countries that have high rate of pollution, radiation, or parasitic infections, there will be an increased incidence of different other types of cancers, right? For example, in Egypt, bilharziosis was endemic for some time. So at that stage or at that time gap, cancer of urinary bladder, in which bilharziosis usually resides in, was increased. The second predisposing factor is the age. We usually fear of cancers in high age, usually more than 55 years. Okay, why? Because as we said that cancers are produced by an interplay or an interaction between environmental or external factors and internal factors. You can suspect that at old age, the body already was exposed to external factors for many, many times that they caused an alteration in the genes of the body, right? So that's why we usually suspect cancers in old age. However, children less than 15 years have certain types of tumors that are predominant in this age specifically. One of them is very reasonable, the blastomas. Blastoma means the tumor that arises from primitive organ cells, like we already explained in the previous lecture, right? So we may expect a blastoma from primitive cells in a child, because usually the child will have primitive cells in his organs, right? Also sarcomas. The sarcoma is a malignant tumor that arises from mesenchymal tissue. Okay, and we already explained that in the previous lecture. Sarcomas of bone and skeletal muscles arises in young age. A third predisposing factor for tumors is the hereditary factors. And by hereditary factors, we mean that in families, certain genetic mutations run in these families, run in the offspring. These gene mutations are mainly present in the genes that control cell proliferation and cell proliferation suppression. Okay? So, in these families, we find, for example, the father having colon cancer, the children, one have breast cancer, one have a prostate cancer, and so on. That's what I mean by a familial or a hereditary factor. The cancer with different types. The cancer occur in many members of the families. Okay, why? Because they inherit specific mutated genes that increase the risk of cancer in these families. Okay, so it is reasonable to find the families with inherited genes and do a regular screening for them for any alterations or changes to detect the cancer early, right, and remove it before causing complications or causing metastasis, right? But we also have a certain implication of being a hereditary factor. We already said that cancers are more in the old age, right? But in families that have familial cancers, the cancers start at younger age group. So we need to do the screening at younger age group. Also, the tumors, either cancers or benign tumors, by the way, can appear in this category. Okay, they can have multiple tumors. Okay, not one. An example for a gene is called RB or retinoblastoma gene. And from its name, blastoma means a tumor that arises from primitive cells. And retino derived from retina. Retina is the layer inside the eye globe that senses the light. Okay? So retinoblastoma is a tumor that arises from the eye globe. Okay? This gene was found mutated at retinoblastoma before discovering that it can be mutated at many other cancers. Okay, but after the discovery of that retinoblastoma is a very important gene that suppresses growth of cells, so suppresses tumor formation, and that it can be mutated in many other tumors. However, the name remained as it already was named, which is retinoblastoma. So some families have an inherited defective retinoblastoma gene. Okay, and in these families, we find that retinoblastomas and bone tumors, which are called osteosarcomas, run in families. Okay. Other external factors may include physical, and physical factors mean factors that are present in the environment, like ionizing radiation, and ionizing radiation can cause cancer of skin. I think it is reasonable, and cancer bone. Ultraviolet rays from the sun can cause skin cancer. Chemicals present in the smoking, in the cigarettes, right, can cause cancer lung. And also hormonal, right, like excess estrogen for a long duration, like those who are taking oral contraceptive pills, for example, for very long duration, very long, it's not a definite cause, but it may predispose to cancer users. Also, some infections can predispose to cancer or to neoplasms, like viruses. For example, hepatitis B virus. This is a virus that causes inflammation of the liver. Okay, hepatitis B virus can cause, on the long run, hepatocellular carcinoma or liver carcinoma. There are also nutritional factors like nutritional imbalance, like in low fiber diet people who don't eat enough vegetables, they may have cancer of colon or adenocarcinoma of the colon. We also can have pre-neoplastic lesions in the body that after some time they can turn malignant. And a reasonable one we already mentioned in the previous lecture is having benign tumors, because we in the benign tumors said that benign tumors may have a susceptibility to turn into malignant. However, the risk varies from one tumor to another. So some tumors have a rare incidence to turn into malignant, and some tumors have a high incidence to turn into malignant. So certain benign tumors that have high incidence to turn into malignant can increase the risk of having cancer. For example, the adenoma. Oma means swelling or mass. Adeno means arising from glandular epithelium. So adenoma is a benign tumor that arises from glandular epithelium of the colon. It was found that adenoma has a high rate of turning into malignant. Okay? Other factors include metaplasia and hyperplasia. Metaplasia and hyperplasia were types of adaptation you already learned in the adaptation in the basic medical sciences modules. But for just a quick revision, meta means transformation. Plasia means growth. So metaplasia is the transformation of growth. In other words, it is the transformation of one type of cells to another type due to presence of a chronic irritation in the area in which the original cells cannot bear anymore. So they transfer to another type of cells that is stronger than them that can bear this irritation. Okay? However, the metaplasia can be precancerous, can have malignant features, and after some time, which is called dysplasia, and after some time they can turn into actual cancer. For example, squamous metaplasia that occur in the bronchi, in the bronchial epithelium of the lung in smokers, okay, can lead to a cancer lung. The same idea applies to hyperplasia, and hyper means increase, plasia means growth. So hyperplasia is the increased growth. In other words, it is the increased number of cells in the tissue. Okay, it is an adaptive mechanism for a certain cause. However, after some time, probably a long time, hyperplasia may have alterations in the cells, turning in the direction of being malignant. Let's look at this picture to understand more. Here we have a certain type of cells, whatever we can consider it normal, or we can consider it a hyperplastic, okay, with increased number of cells, or can consider it, or we can consider it metaplastic, okay, from another type. Either normal hyperplasia or metaplasia, they don't just invade the underlying tissue and become malignant. They transform in a process. And the first part of this process is having microscopic features of malignancy, which is increased nuclear cytoplasmic ratio, hyperchromatism, pleomorphism, increased mitosis, abnormal mitosis, but without invasion of the surrounding tissue. Okay, so this tissue is intact. The basement membrane, the membrane that lies just below the cells, is not invaded, is intact. This is called cancer? No invasion, so it's not cancer. This is called dysplasia. So dysplasia is the atypical presence of features of atypical cells in the epithelium without invasion of the basement membrane. But after this, sometimes this dysplasia will form invasion like that. And in this case, we call that malignant tumor. Okay? So let's focus a little bit on epithelial dysplasia. And as we already said, epithelial dysplasia is a typical proliferation of cells that have criteria of malignancy without invasion. Okay? And it usually occurs due to chronic irritation. Why? Because of the presence of chronic irritation makes cells try to proliferate and die and proliferate and die. Okay? And not all dysplasias turn malignant by the same percentage. That's why we need to set a grade for the dysplasia. If the dysplasia is on a few cells, it's called mild, more cells, moderate, or all cells, it's called severe. This apply on this picture here. Here, this is a normal tissue, but here we have these abnormal cells with large vesicular nuclei, right? And loss of polarity, right? They don't respect each other, right? But these abnormal cells are taking around 1/3 of the tissue. So this is called mild dysplasia. But here, the abnormal cells are in the whole tissue, right? Taking all layers long, right? This is called severe dysplasia, or in other words, carcinoma in situ. Carcinoma means what? Carcinoma means the malignant epithelial tumor, right? Because dysplasia here is in the epithelium. In situ means what? In situ means with no invasion. In other words, it means that there are cells that look malignant in morphology, but they don't do invasion in the surrounding tissue. So they are not cancer, right? But we name them dysplasia, and if the cells occupy all the layers of the tissue, we name them severe dysplasia or carcinoma in situ. And severe dysplasia or carcinoma in situ will enter after some time the next stage, which is invasion of the surrounding tissue, and in this case it is called a cancer or a malignant tumor. So here let's compare the nuclei of this tissue in size and in staining. And here the nuclei are larger, right? And darker, right? This is a dysplasia. This is some of the features of malignancy under the microscope, but no invasion here, right? The underlying tissue has no invasion, right? But then when we decide to say that this tissue has dysplasia, we need to set a degree or an extent. So here, I think that these plastic cells are actually taking the lower part of the tissue to some extent, right? This is called mild dysplasia. But here, the nuclei that are large and hyperchromatic are taking more tissue, right? This is called moderate dysplasia. And here, the nuclei, here is a large nucleus vesicular. This is a hyperchromatic nucleus. The nuclei are different in size and shape, right? And the features of malignancy are up to the surface of the epithelium. This is called severe dysplasia, and this is precancerous. So carcinoma in situ is a pre-invasive carcinoma. Okay, no invasion in this stage. Some scientists call it intraepithelial carcinoma because the features of cancer are present in the epithelium, in the whole epithelium, but without invasion. In gross pictures, they don't appear as a mass. They just appear as a thickening or hardness. Induration means hardness of the tissue. They are not a tumor, so they don't form mass, right? And under the microscope, we can see features of malignancy, but without invasion. And the fate of them after some time, they will turn into invasive cancer and will invade the basement membrane that lies under them. So, by the previous items or topics, we explained the pre-cancerous lesions, right? And the external factors, right? But we still have, and some internal factors like inherited genes in the familial tumors. But we need to explain in more details the endogenous factors, the mutation in the genes responsible for proliferation to understand why tumor forms. By the previous causes, either predisposing factors, either external environmental factors, either as whatever the cause, the external cause, it interacts with the genes present in the body and causes their mutation, or interacts with an already mutated but still silent gene and causes its expression. But we need to know what are the normal genes that are responsible for the growth of our cells to understand what is a possible mutation that can cause cancer or a tumor in general, by the way. We have genes that stimulate growth of cells, that stimulate proliferation of cells, but within a limit. These genes in the normal situation are called proto-oncogenes or growth-promoting proto-oncogenes. Imagine that there is a mutation in a proto-oncogene. The mutation led to more activation of this proto-oncogene. So the result will be a more proliferation of cells, right? Which is called a tumor, right? So a mutation that causes stimulation of the or activation of the proto-oncogenes can cause a tumor. In this, in the activated proto-oncogenes, okay, the mutation that causes activated proto-oncogenes, we don't call it proto-oncogenes anymore, but we call it oncogenes. So oncogenes are the mutant form or the overexpressed form of the proto-oncogene that causes continuous cell proliferation without any control. The second type of genes is genes that inhibit growth in the normal state. And as they inhibit growth, they are called tumor suppressor genes, okay? Because they suppress tumors, they suppress abnormal proliferations, okay? And they are growth inhibitors, okay? If some of these genes or one or these genes had a mutation that inhibit its function, that inhibit the gene from inhibiting growth, so the result will be a continuous proliferation, right? There are two major genes that protect the body from continuous proliferation or are called tumor suppressor genes. One is called P53 gene, protein 53 gene, and the other is called the retinoblastoma gene that we already discussed previously in this lecture. The third type of genes that regulate the cell growth and makes sure that the cells have normal DNA content after division are genes that are involved in DNA repair. So if a mutation is present in one of the genes that form or that are responsible for the DNA repair, the result will be unrepaired abnormalities of the DNA, right? So cells with unrepaired faulty DNA will continue to proliferate with this faulty DNA and form a tumor. The fourth set of genes are genes that regulate the programmed cell death or regulate apoptosis. And apoptosis is the cell suicide that occurs if cells have abnormal DNA without repair. Imagine that there is a mutation in the genes responsible for apoptosis, so apoptosis is inhibited. No apoptosis will happen. So faulty cells will continue to proliferate and form a tumor. So these are the four genetic classes that can have mutations that will lead to cancer or even a benign tumor, by the way, formation. Detection of these genes, these mutated genes, can help in both diagnosis of the tumor and finding a treatment. And in cancers, the changes in these genes is a multi-step process, by which I mean that at first there is a small mutation in one or two genes, right? So the tumor will acquire the abilities to divide without control. But with more proliferation and division of that tumors, especially cancers, there will be more accumulation of genetic alterations that will lead to more aggressiveness of the tumor and more malignant potential and more tumor progression, okay? And more increase in tumor size and more resistance to therapy, okay? So further, after the initiation of the abnormal cell proliferation, further mutations happen in the offspring that will lead to that the cancer will acquire further criteria of malignancy. So like what? Like self-sufficiency of growth signals, which means autonomous proliferation, insensitivity to anti-growth signals, which means autonomous proliferation without stoppage, and to escape apoptosis, right? To escape apoptosis, so they will not commit suicide because they are abnormal, and to create new vessels that supply them with more blood, thus angiogenesis, and to acquire criteria of more invasion and distant spread with limitless replicative potential. So, what about the benign tumors? Benign tumors can have also genetic alterations that make them proliferate without suppression and so on, but the genetic alterations don't lead to a very aggressive tumor, don't lead to acquiring invasive criteria, right? So the basic idea of genetic alteration and maybe a cause of environmental cause interplay may take a role. However, the result is still limited or still benign. Our third objective for this lecture is discussing in further details the spread of malignant tumors. We already mentioned that tumors can spread by direct invasion to the surrounding tissue or to the nearby tissue, or by sending distant metastasis or distant spread. And we already mentioned in the previous lecture that tumors can send distant spread by lymphatic vessels or by blood vessels. But we need to elaborate more on these routes of spread and also discuss more routes of spread. So this is the direct spread. Just as a reminder, these are the malignant cells, and this is the invasion. This is the direct spread, right? We, in the video of the previous lecture, said that as cells invade the nearby tissue, this is called direct spread. Let's see here, in this stomach, we have a cancer, right? And this cancer, by the way, metastasis and invasion occur only in cancers, in malignant tumors. This cancer, after some time, it was in the first layer here. After some time, it invaded the second layer. After some time, it invaded the third layer. After some time, it invaded the fourth layer. This is called direct spread. After some time, it entered the nearby organ, the next organ, the organ is to it, which is the spleen in this case. This is called direct spread, okay? However, in metastasis, tumor sends secondary implants, okay, in other organs that are discontinuous from the primary tumor. They are located in remote, in distant tissues, okay? And metastasis occur in a malignant tumor. But we had already mentioned that there is a type of which is called by behavior locally aggressive or locally malignant. Locally aggressive or locally malignant tumor do direct spread only, but they don't send metastasis. They very, very rare send metastasis, and in this case, we name them malignant. They have malignant behavior, not locally malignant behavior. Okay? An example, because we are in the locomotor module, is the osteogenic, or osteo means bone, genic means generate, osteogenic sarcomas, which are the bone sarcomas. Malignant tumors are from bone, and they usually metastasize to lungs at time of initial discovery. So the child presents with the cancer in his bones, and unfortunately a lung metastasis. And generally, the more anaplastic and the less the differentiation of the primary tumor and the larger size that the tumor is, the more potential for metastasis can occur. Here, look at this picture. This is a cancer. The cancer can send cells through blood. This is called hematogenous spread, or through lymphatics to lymph nodes. This is called lymphatic spread. And this photo is just for imagination. Look for this cell. This cell is a malignant cell. Okay, it's one of cells among tumor cells. But this cell started changing in shape, started transformation and preparation to leave its place and move into the next part of the tissue, which is called invasion, or maybe move and enter a blood or a lymphatic vessel, which is called to cause metastasis. In this lymphatic spread, we just want to remember every organ drains, every organ receives an arterial supply, then drains by venous blood or a lymphatic drainage. So, and this lymphatic drainage takes the lymph from the organ and goes to a police station, which is called lymph nodes, right? Like these yellow ones, okay, that filter the lymph, right, and distract any foreign material or foreign bodies inside it. Okay, imagine there is a case of a breast cancer in the breast, and the cancer cells, to do lymphatic spread, will enter the vessels, lymphatic vessels, and go to the lymph nodes and implant themselves in the lymph nodes and then start proliferation. So secondary malignant tumors will arise in the lymph nodes. This is called lymphatic spread. And the lymph nodes enlarge in size. And under the microscope, we will see foreign cells with large nuclei and dark nuclei and pleomorphism, right? Inserted or implanted in the normal lymphatic tissue, which is the blue one here. And this is the malignant metastatic cells. This is called lymphatic spread. However, not any lymph node enlargement in case of a tumor is called lymphatic spread. We need to do a pathological examination to see if this is a true lymphatic spread or a metastasis in the lymph node, or this is just an inflammation, an immunological reaction to the tumor cells. Okay? The second type of metastasis is the blood or hematogenous spread. Here we see some of the cells, malignant cells, they left the primary malignant tumor here and attached it to the vessel and then inserted themselves inside the vessel and flowed with the blood and then exited from the vessel to a new tissue to form a new secondaries, or to implant in a new organ and form secondaries. This is called hematogenous spread or blood spread. And actually, veins which drain blood from tissues have more weak walls than arteries. That's why malignant cells invade the veins, not the arteries, to spread to other tissues or other organs. And by the way, we found that there are some organs that are that have a more potential to receive the metastatic cells, like the liver, like the bone, like the brain, like the lung. They call them liver L, lung L, bone B, brain B, LLBB. Okay, so LLBB are common sites for hematogenous metastasis. And also we have the kidney, which is called renal in the Latin, and a suprarenal gland, which is the adrenal gland. So some people call it R from renal and R from suprarenal. So the common sites for hematogenous spread are the lung, liver, brain, bone, renal, and suprarenal glands. Okay. And by the way, sarcomas, which are the malignant tumors that arise from mesenchymal tissue, love hematogenous spread more and do it earlier than carcinoma, because sarcoma arises from mesenchymal tissue, and mesenchymal tissue already have rich blood supply. However, carcinomas arise from epithelium, and usually the epithelium don't have blood supply. It receives its blood supply from the mesenchymal tissue underlying it, right? So sarcomas spread early by blood, while carcinomas usually spread early by lymphatics. Here we need to examine the shape of the metastasis. Here, this is the lung, this is the liver, and this is the bone. It's a vertebral column, and there was a primary tumor in whatever organ. Then this tumor sent metastasis, which implanted in the lung, like this. All these variable sized masses are metastatic cancers. Every one was a small initial one that continued to proliferate to form secondary tumors, right? So this is metastatic cancer in the lung. The same applies to the liver. This is the liver. It should be all brown. But what are these masses? These are implantations of malignant secondaries from an original tumor. Also here in bone, do you see these white lesions? Multiple, numerous, very numerous whitish lesions. These are metastases from a primary tumor. So this is bone metastasis. So metastatic nodules appear multiple and variable in size and shape, and usually paravascular near the vessels, because already the malignant cells already reach the organ from vessels, so they will seed around these vessels, right? And they may show central umbilication, and by central umbilication we mean that the center of this part, the center of the implanted nodule is depressed. Okay, it's called central umbilication. So if we have a malignant primary tumor in whatever organ, X organ, and this tumor will send a blood spread to metastasize in other organs. Which organs will receive the metastasis? This differs from a cancer to another and from an organ to another. So we have molecular basis, we have different bases that makes some organs the preferred organs for as a site of metastasis for some cancers. Like for example, in prostatic carcinoma, the cancer that arises from prostate, hematogenous spread usually loves bone. However, in other organs like skeletal muscle, although rich in capillaries in blood supply, they are rare site for secondary deposits. They are not a favorable site for cancers. So let's focus more on metastasis of bone. Metastasis of bone occur more in the red bone marrow of vertebrae, flat bones, okay, ribs, sternum, and ends of long bone. Here in the vertebral column, you see this is a breast cancer, this is a kidney or renal cancer, this is a lung cancer, and they send cancer cells through blood that implanted in the vertebral column, like that, right? The vertebral body. Most bone metastases are destructive. They cause lysis of bone, which is called osteolytic. Lytic means lysis, osteo means bone. Let's look here at this image. For the vertebrae, we see a rarefaction, multiple rarefactions, right? These are lysis foci inside the vertebral column. These are metastases from a cancer elsewhere. They caused destruction of the vertebral bodies, which gave us the shape of lytic lesions like that. However, some tumors don't cause lysis of the bone. A famous one is a prostatic cancer. It causes an activation of the osteoblasts that cause more bone formation. So the metastasis is called osteoblastic or osteosclerotic. Sclerotic means dense, like that one. You see? Whitish areas of more bone formation over the vertebrae. This is osteosclerotic metastasis. And when we see something like that, we always think prostatic cancer if the cancer is in a male patient. Because the prostatic cancer secretes an enzyme called phosphatase that causes more deposition of bone. So if we have a patient with a primary cancer, we need to search for a metastasis. And we usually search for the famous organs for metastasis: liver, lung, brain, bone, renal and suprarenal, kidney and adrenal gland. So we do chest CT to see if there are metastases in the lung. And we do abdominal and pelvic ultrasound to see if there are metastases in the liver and the kidney and the adrenal gland. Okay? And we do a bone scan to see if there are metastases in the bone. Okay? So this is the routine for any cancer. By that, we already explained the direct spread, and from the metastasis we explained lymphatic spread and hematogenous spread. there is a third type which is called transcoelomic, and by transcoelomic we mean via serous sacs, which are the pleura, pericardium, and peritoneum. And for example, this stomach has peritoneum underneath it here. Cancer cells will move from the stomach, which have cancer, along the peritoneum to reach the ovary and implant in the ovary to form secondary tumors. This is called transcoelomic spread. Okay. Another one is here, the colon cancer, that sent some of the malignant cells along the peritoneum to this part of the peritoneum is called omentum and caused secondaries here. This is called transcoelomic spread. A fourth type of spread is called perineural, and peri means around, neural means nerves. So perineural spread is spread along the nerves. And to understand that, let's see these pictures. Here is a nerve, okay? And the nerve is composed of axons of many neurons, right? And here is the malignant cells. The malignant cells just attract to the nerve, and do you see here? They invade the nerve and go and spread along the nerve like that. Do you see this picture? Here is a tumor here. Okay, by the way, it is in the prostate. And then the tumor, do you see the orange arrows? The tumor cells spread with the nerves here to reach, wait, what is that? The spinal cord, in the right? And then spread by nerves to go to other sides. This is called perineural spread. Under the microscope, and it is just for illustration, let's see here. This is the nerve. It is a longitudinal section in the nerve, and around the nerve resides many large cells with large nuclei, dark in color, with mitosis, right? And vesicular nuclei like here, and bizarre cells. These are malignant cells. Okay, and these malignant cells are following the nerve. They are perineural inside, right? And they spread through this nerve to other organs. When we take a cut section here in this nerve, we will see around this section, which is that this is a nerve, the transverse section, and it is surrounded by cells that have large, dark, hyperchromatic nuclei. These are nuclei of malignant cells. And by the way, this is the malignancy here. It is nearby to the nerve, right? So this is called perineural spread. And by the way, prostatic cancer is a famous one that loves perineural spread. Okay. There are other types like implantation, in which tumor cells just fall from the original tumor to the surface of an organ that lies down to the level of the original organ. Like kidneys, urinary bladder lies under the kidneys. So if there is a tumor, a renal tumor, a malignant tumor, some cells may fall off from the kidney and fall on the urinary bladder and form metastasis. And in this case it is called implantation metastasis. By this, we reach the end of the first part of our lecture. I hope that it was easy to understand, but I need to focus on something regarding all the pathology. We usually explain for you the general common rules. However, all rules have exceptions, so don't forget that in any disease. Part 2 will be held on Zoom on the next Saturday. It will be an interactive one, and it will be recorded and then uploaded to your learning management system, God will. And don't forget to deliver your first assignment, which the due date will be at 8th of April, 11:30 p.m. And thank you. Good luck.